All right, well, it's close enough to time. Let's go ahead and get started so we can get you out at a decent time. Does everybody have a handout? There are 2 clipboards running around. Please sign up to make sure that we have your attendance. If you haven't signed up, please do so before you leave. But thanks for giving me your time. We're going to talk today about CPR and mostly about the basic CPR, basic life support. There is a whole other course, a whole other lecture about advanced life support that's beyond the scope of what we're going to talk about today. If at any point you can't hear me or if I'm talking too fast, please just wave me down. So let's talk about a little bit about CPR by the numbers, so to speak. What we're looking at is on our patients that we have to do CPR on, we're looking at approximately 6% survival to discharge. This is not the same percentage as the amount of patients that we get their heart rate back, the return of spontaneous circulation. That percentage is a little bit higher. This is talking specifically about the patients that we get back and actually go home. Probability of repeat cardiac arrest is very high. Most patients will rearrest, and they will usually do so within 6 hours of getting them back the first time. Ischemic damage just means the damage of lack of blood flow to the tissues. Starts within the first 4 minutes, becomes irreversible at the 10-minute mark. Anything beyond 10 minutes is considered prolonged cardiopulmonary arrest or prolonged CPA. And typically, we're not going to continue our efforts past 20 minutes. Clinical and ethical indications oftentimes will lead us to discontinue. At this point, after 20 minutes, most of the time, just because we can continue does not mean we should continue. So I put that at the very beginning of the lecture so that we can all have a good understanding about we have a lot to do in a very short amount of time in which to do so. So that's why we're all here today, is so that we know ahead of time what we're expecting, what our expectations are, what our roles are, so that way when it does come time, we're not, quote-unquote, wasting our time trying to figure out who's doing what, because we all know ahead of time, going into it, what are our expectations. A CPR team consists of 5 people. The leader, the compressor, the ventilator, the drug handler, and the recorder or the scribe. Now during the day, that 5 people seems like not a big deal when we have a hospital full of people. At night, when we're down to only 5 people in the entire hospital, sometimes each person is going to have to pull double duty. I also want to point out, though, during the day, even though we have the luxury of having 15, 20 people available, this is not a situation where more hands is more helpful. So, of course, if we have a code, please check to see if you can be helpful. However, please do not do so to the detriment of the rest of the patients that are in the hospital. Even though we have a code and it is exciting to see and it is exciting to learn, we still have a hospital full of other patients that still need our help. If you've never seen a code and you want to learn, provided that you have the opportunity to do so, please feel free to stand by and to learn, but please do so from a distance so that when these 5 people have all of their hands going in 15 directions, that they're not bumping into you. So then very briefly about the order of operations, this is what we're looking at when we have a code. Alert the DVM and assign a scribe. Those are the first 2 things. You say loudly or grab a tech or somebody, hey, I need a doctor right away. And you're going to grab that person, you're going to grab that patient, and then the nearest, and it's going to likely be an assistant that's going to be a scribe. That's going to be the first thing to do. A technician or the doctor will start CPR immediately, while another person then tries to determine if the patient is indeed completely in CPA. You will start chest compressions first, because a delay in starting chest compressions, if there's not a heartbeat, is more detrimental than starting compressions if we still do have a heartbeat. Does that make sense? So then we're looking at our ABCs, and you'll notice that D and E made it up there too. That's a little bit, that's borderline heading into the advanced life support, but it's on there anyways. So we have airway breathing. This is where we have the intubation. Either a technician or the doctor will do the intubation, and the person that does the intubation will attach a capnometer. and then begin the assisted ventilation at 10 breaths per minute. While all that is occurring, another person is doing the chest compressions, and then a third person is attaching the EKG leads. I want to point out here that a lot of us have gotten in the habit of just using alcohol to wet those EKG leads. I'd like us to switch to using saline. Alcohol is flammable, and in those rare cases that we do need to use the defibrillator, it's not such a good idea to have the alcohol on there, because while I have not seen flames actually on a patient, it can happen, but I have seen significant burns and quite a smoke show occur. So saline, and then apply any ultrasound gel that's up on that crash cart, and that'll help keep the connections better. So that's all happening while yet another person is the drug person, obtaining venous access, drawing up and administering medications as directed by the doctor, and then our EKG is up there so that we can keep track of things. But I do want to point out that analysis of the EKG needs to happen in a very quick succession, and it is not something that we are going to stop our chest compressions to check the EKG. That is something that is newer in the last, 5 years or so. Do not pause between the chest compressions in order to analyze that EKG. Alright, so let's talk about the leader. This is going to be the DVM. This is not going to be anybody but the DVM. The doctor is the one that calmly drives the code. The doctor's voice needs to be heard above all else. The doctor organizes the team, assigns roles, monitors the effectiveness of our CPR performance, gives constructive feedback and when indicated, ordering the drugs, the fluids, the fluid boluses to be given, monitors the patient's response. The doctor will only help with chest compressions if they're absolutely needed, meaning we're down a person, we don't have enough people to change out chest compressors to allow for adequate rest. So typically this is going to be at night. It is not possible to do effective chest compressions and run a code at the same time. You can't do effective chest compressions and monitor all of the response at the same time, so we do not want our doctors doing these chest compressions. This falls solely to the technicians.
Please remind them of that.
They have had this. What I'm telling you now is the doctors... What we're talking about now is based on what the doctors have already discussed. That's why we're coming in behind what the doctors have already discussed. This is all not news to them. This is us coming up to speed with where the doctors are at now. And then the doctor will be in charge of client communications and relaying realistic expectations to these clients. On that note, what we want to try to do is on any patient that we have a code on, if that client is in the hospital, we really want to try and get those clients into room 4 whenever possible, so that when the doctor leaves the code table to talk to the clients, they're not going all the way up to room 1 or all the way up to room 9. We want them to be as close to that stat table as possible. When the doctor leaves to do these communications, the doctor will assign a new leader in their absence with clear instructions. They will say, Casey, you're the lead. I need you to do in 2 minutes, do X, Y, and Z. If you're not seeing a response, I want you to do A, B, and C. I will be back by then. If X, Y, or Z happens, then come get me. But the doctor will assign and leave specific instructions as to what should be done in their absence. So let's talk a little bit about chest compressions. Again, this falls to the technicians. If we happen to have 2 doctors and a doctor wants to take turns doing chest compressions, as long as they're not leading the code, it's fine. But the rest of the time, it's going to be the technicians that are going to be doing these compressions. The patient can be either in right or left lateral recumbency. But I do want, and this is from the Recover Initiative, consider sternal compressions or dorsal recumbency for barrel-chested breeds like our bully breeds. And that's sheer physics. So let's think about whenever you're learning and for your first aid, your basic CPRs at Red Cross for humans. Our chests are wider than we are deep, so they lay us on our back so that they can do effective chest compressions. Same thing with these bully breeds. They're typically wider than they are deep, so we're going to have more effective chest compressions if we have them in a V-trough on their back. The Other breeds like the greyhounds or most of the rest of the dogs, they're going to be more narrow than they are deep, so that's when you're going to have either right or left lateral or compensate. The compression should be between 100 and 120 beats per minute. A lot of us sing songs in our head while we're doing this. It depends on if you're a positive poly. Staying alive, that nice beat, that's how fast you have to go. If you are a negative Nancy, this one works well. But if you can find that beat, that's how fast you have to go. You have to do these chest compressions that quickly. If you just like Star Wars, this one works as well. This one you have to give a sec to get to the beat. That. This one's a little bit on the slow end. This is actually only 104 beats a minute, where the other two are closer to 120. If you're not musically inclined, or you just can't find a beat to save your life, do the best that you can to do 2 compressions for every second. The other part of it is you want to make sure that you're giving hard enough compressions. You should be compressing that chest 1/3 to 1/2 of the width. That's a lot of force that you're putting behind these chest compressions. That being said, you want to allow for full recoil, meaning you're not leaning on that chest. When you're up and you're doing chest compressions, this is a time where you want to lock your elbows. You want your shoulder over your elbow, over your wrist, both hands on that patient. You're going to use your core, so you're going to be using exercises, but you're going to push. You're going to use your body weight to push. I don't care how strong you are, you cannot get adequate compressions bending your elbows. You're not strong enough to do it, and you will not last 2 minutes. Compressors change out every 2 minutes. Whether you feel tired or not, trust me, change out at 2 minutes, because you're going to start leaning on that patient, and you're not going to pull yourself up all the way up off that chest. Another thing about chest compressions is the end tidal CO2. Now, sometimes that's a little counterintuitive. Your end tidal CO2 is often associated with respiratory issues. But if you think about what that is, your end tidal CO2 is the carbon dioxide, basically, that you breathe out. And where does that carbon dioxide come from? It comes from cellular metabolism. So the cells in your feet are breaking stuff down, creating carbon dioxide. It's the heart that pumps the blood, that picks up that carbon dioxide, brings it to the lungs to be breathed out. So if the blood's not circulating, if the heart's not pumping, you're not getting an end tidal CO2. So that's why we have to have it on there. Now, your end tidal CO2 should be greater than 15 if you're doing adequate chest compressions. If it's below 15, consider pushing harder, pushing faster, or changing compressors. If it's 0, check your ET tube placement to make sure you don't have an incidental esophageal intubation, because you should be getting at least some number if you're doing some kind of respirations. And then we're also monitoring that very closely, because a rapid increase in this number is the first indicator that you're going to get to return of spontaneous circulation. So let's say I'm working real hard, my chest compressions I'm doing good, I'm getting 16, 17, and then all of a sudden it jumps up to 35. That moment is when the heart has likely started pumping on its own again, and that moment needs to be noted on their CPR logs. Doesn't mean that I'm going to stop, even if it happens if I'm in the middle of my 2-minute cycle. I'm not going to stop, it's just going to be noted. And then again, we're not stopping compressions at any time. Whenever we're changing compressors, I want the next person that's taking over to be right at my either right or left side, I don't care, but right there to start immediately taking over. Pauses of greater than 10 seconds in these chest compressions is shown to be, it drops the aortic blood pressure. It takes a full minute of very good chest compressions in order to get the aortic blood pressure to reach a steady state that provides adequate perfusion. So if we're thinking back to that very first slide that we were talking about, and we're thinking about our timeline, we're starting chest compressions right away, but we're not essentially having much benefit of those for a full minute. So stopping for another 10 seconds means that we've put ourselves again at time 0, and we have to do chest compressions again for a full minute in order to get that blood pressure back up to where it needs to go. So this is why we don't check the EKGs. We do not stop chest compressions to check EKGs. If we do, we're only doing it for literally less than 10 seconds. And we're having that next compressor right there with us to take over as soon as we back off. Respirations. Intubation will often need to occur with a patient in lateral recumbency. We do not have the luxury of sitting these kids up in sternal and intubating these patients like we're normally used to learning, especially when we were in school. So I want you to consider practicing lateral intubations on your next stable anesthetic patient. Now, if the patient's not a stable anesthetic candidate, then certainly don't practice on that one, because we don't want to code that one. But if we have a patient that you can have that luxury of practicing, please do so, because it's a slightly different feel if they're on their side versus if they're on their chest. And doing lateral intubations on a stable patient, then when your adrenaline's pumping and your patient has coded and now you have to do it for real, you know that you can do it, you've done it before, you can just breathe through it and get it done. Respirations are 10 breaths per minute, which is approximately 1 breath every 6 seconds. Inspiratory time of about a second, allowing with a rapid and full exhale. Never exceed 20 centimeters of water on the manometer, on the anesthesia machine, or if we're using an ambu bag. Now there's these dial of pressures that you can make sure that it's not going to be, whenever you use that ambu bag, and once it hits 20, it blows off any excess, so we're not going to run the risk of popping a lung, so to speak. It is very important to not hyperventilate the patient even though you're hyperventilating. Your adrenaline's running, you're wanting to breathe. This is not a case where more is better. Respirations, now you'll notice I don't have a doctor or a technician designation on this one. This is going to be one of those things where if we are not having the full 5 people, this is going to be something where the assistants are going to help us out with. Then the drug handler draws up and administers medications as directed by the leader. Closed loop communications. Has anybody heard of closed loop communications or knows what I'm talking about when I say that? So the best way, it's just a lot of repeating. The best way to explain it is to just use an example. So let's say I have a code. Gavin has given me instructions. I want 0.3 mils of atropine IV. That's what he says to me. So I grab the atropine, 0.3 mils of atropine, and I'm repeating it as I'm drawing it up. We're doing that for several reasons. One, to make sure that I heard him correctly, and to make sure that he didn't mean, oh, no, I meant 1.3. Because his adrenaline's pumping just as hard as mine is, so that is the initial repeat. Then I'm also repeating it again as I'm giving it. That is again to make sure that we're not forgetting anything, but also to make sure that the scribe, who is writing all of this stuff down, is hearing that it's actually in, that we're not just talking about maybe he needs the atropine. No, atropine IV is given and the amount. If for some reason I'm handing that syringe to somebody else to give, I'm repeating it for a 3rd time. I'm repeating it when I draw it up, I'm repeating it when I hand it off, and then it is getting repeated when it is being administered. This is not optional. This is crucial to make sure that we are administering everything that the doctor ordered, that we're administering everything in a timely manner, and that everything is actually getting written down. We will administer drugs every 2 minutes, specifically atropine. That's going to be given usually about every 2 minutes or every cycle. Epinephrine is usually about every other cycle, every 3 to 5. It's not common that we're going to do epinephrine every 2 minutes with the atropine, but it does happen sometimes. Again, those decisions are at the discretion of the doctor. We have the recover chart, and this is by the stat table, but it's just a very brief, quick and dirty, general doses of epinephrine. You'll see there's a low dose and a high dose. Remember how, again, when we were talking about the first 10 minutes of CPR, we're typically going to use the low dose of epi, But once it's technically prolonged CPA, usually that's when you're going to hit them with that high dose of epi. Then there's, of course, on there atropine, and then we have the, there's defibrillator shock doses down at the bottom of that too. Then we have the scribe, and this is 9 times out of 10 going to be the assistant, or an assistant that is there. The assistants need to be very familiar with our CPR patient log sheets. There is one attached to the back of the handout that you all have. The front part of it is where you have the epinephrine, atropine, defibrillation, dopamine. Everything is going to be written on there. Become familiar with it before your next shift if you are not already. Now the scribe cannot be shy. You are just as instrumental to the CPR code as anybody else. We have to be able to hear your voice. You are the one that is secondary to the team lead, to the lead. I have to hear your voice. We have to know what times we're looking at. You have to say, okay, we gave atropine 1 minute ago. We gave atropine 2 minutes ago. We have started chest compressions. We're about 30 seconds out for the next chest compressor. Please don't hit us at the 2-minute mark so that we're scrambling to find the next compressor. Give us a few seconds so that we can get that next person up and ready. Because again, we cannot stop for longer than 10 seconds or we're kind of shooting ourselves in the foot. So this scribe, this assistant or technician, but the scribe has to be just as vocal as the doctor is about times, when we started, when we gave the drugs, etc. The scribe is also keeping track of everything, writing down all the blood work, all the procedures. If there's IV fluid therapy going, we're writing down the types of fluids, the boluses, the amounts, the times, everything. And then the end-tidal CO2, remember we were talking about how important it is to monitor that. You have to monitor that as well, and there is a spot to record that on the front of the sheet. This corner here is where the end-tidal CO2 monitoring is. Here's the time, the column for the number and the time. Right over here it says ROSC. There's just a yes or no at that point. But here's where you can write mils and times of the drugs. If you are not sure if there is a drug that the doctor is ordering and it's not on this list, for example, mannitol sometimes would be something that would be ordered, just write it down here, other drugs. And do the best you can with spelling. Spelling doesn't exactly count. Just do the best that you can. Down here at the bottom is plenty of room for writing notes. If you cannot find a specific spot for it, just write notes down at the bottom. BG was 112, lactate was 7, something. Just write it on this sheet for us so that we can keep track of it. And we will fill out for each CPR event. Remember again how we talked about if a patient codes and we get them back, the likelihood of them re-arresting within the first 6 hours is pretty high. So let's say we've done CPR, we've got them back, they're still intubated, we're keeping an eye on them, and an hour later they code again. We're grabbing a new sheet. We're treating each code as a separate incident. We'll talk briefly about defibrillation. Again, Hollywood kind of has us snowed when it comes to CPR's codes and defibrillation. In veterinary medicine, the 4 most common arrest rhythms that you're going to see, EKG rhythms that you're going to see in veterinary medicine, there's only 2 of those that are shockable, and it's actually really uncommon that we're going to see those. We're not going to shock our patients very often. Again, the non-shockable arrest rhythms are the most common: pulseless electrical activity, or PEA, or asystole. The 2 shockables are pulseless VTAC or ventricular fibrillation, VFib. I do want to take a second to point out pulseless VTAC is not the same as ventricular tachycardia. Ventricular tachycardia, if they're perfusing, if they're having any pulses, this is not the same. We still will have patients that are in VTAC, they're dropping some pulses, their pulses might not match their EKG, but they're still having pulses. We are not going to shock these kids. And then ventricular fibrillation. This is more of an FYI. We do have a biphasic defibrillator. These kids are going to be in dorsal recumbency on a blanket or a mat or a V-trough on the table. Do not put them directly on metal. If we have used alcohol on these kids, we want to rinse it off with saline as much as possible. And I mean rinse it, rinse it, rinse it. I would rather have a hypothermic patient that's not on fire. This is where Hollywood did get it right. Clear. All clear, something loud and something to designate that all hands off this patient. And then the doctor will administer the defibrillator. Paddles over the 4th to 6th ribs, which is basically the armpit, and they are going to push hard. Then the compressions will resume immediately after that shock is done. You will not analyze the EKG. Remember, we can't stop compressions for that long, so we're going to start with another full 2-minute cycle of CPR like we were before, and then the doctor will take a few seconds to see if they have had a change in their EKG. Asystole, pulseless electrical activity. Now this looks like a pretty normal sinus rhythm tracing, and you can have that, but these kids are not conscious and they are not having pulses. These are non-shockable rhythms. The 2 shockable rhythms are pulseless VTAC, which is here, and again, sometimes we'll have patients in ICU and their EKG legitimately looks like this. Most of the time it's going to be a splenectomy kiddo or some kind of heart condition or hypoxic event, trauma of some sort. But most of the time the kids in ICU are at least conscious or arousable, and they do have some pulses. Again, it might not match completely with each one of these, but they're going to have pulses. We're typically not going to shock these kids. And then VFib. We're going to take just a few seconds to touch base on open chest CPR. Open chest CPR is very uncommon in veterinary medicine. It should only be reserved for very few reasons. The doctor will consider it if the patient has pericardial effusion, in which case closed chest CPR has been proven to be completely ineffective in these cases. If the patient has significant pleural space disease, thoracic trauma like rib fractures that preclude us from doing chest compressions, or if closed chest CPR has not resulted in ROSC. Oftentimes they'll be considered if the patient is greater than 35 kgs or roughly 80-ish pounds. It is very rare that you're going to do open chest CPR on a cat. You're not going to do it on a small dog. At that point, our compressions are typically effective enough on such a small chest space. If it is going to be done, it needs to be done right away, sooner rather than later. Should start within 1 to 2 minutes of starting closed chest CPR. So this decision needs to be made between the doctor and the client immediately. The approach will be on the 4th intercostal space on the left side. A right side approach can be considered if there's tamponade. I put down at the bottom that there is a major artery that runs about 1/3 of the way up the chest from the sternum. I put that in there because if we're going to do this open chest CPR, 9 times out of 10, we're going to be the ones that are going to be doing this prep. Shave big, shave wide, shave high. Do as best of a scrub as you can. Sometimes we'll just squirt betadine on it and call it a day. I also want to point out that we're going to have some minor verbiage changes on our treatment plan estimates as far as our resuscitation directives. Right now it's surgical, medical, and DNR. DNR will maintain. The other options, the 2 are going to be combined into 1 to try and kind of clarify things. A lot of these owners don't understand what we mean when we say surgical. They don't understand that open chest, that if they choose surgical on a cat, we're probably not going to do it anyways. So there is going to be some minor verbiage changes to the effect of, do you choose CPR? Which would, yes. If the doctor indicates that a surgical approach would be necessary, do you want us to choose that? Then that way it is not on the client, who doesn't have the education that we have, doesn't have the experience that we have. They don't understand what we're asking them. Even if we sit and explain it to them, they still don't. They've never seen it. They don't understand it. So we're trying to take that burden off of them, but also making a more informed decision, because not everybody is a candidate for open chest CPR. Even if the clients are asking for it, does not mean that that patient is a candidate for open chest CPR. And then very briefly about post-arrest care. We will maintain these patients, we will maintain intubation for 4 to 6 hours at least, sometimes longer, depending on the disease process that caused them to code in the first place. Blood pressure monitoring is excruciatingly important. Dopamine CRI will be needing to be started as soon as we have return of spontaneous circulation. We want normal or slightly higher than normal blood pressure to help aid with brain and heart perfusion. Because remember, our heart is an organ in and of itself that it needs to be perfused as well as the rest of our bodies. Passive hypothermia is actually beneficial. We can do slow rewarming of the patients, but typically we're going to stop rewarming at about 98 degrees. We want them to be a little bit colder. Monitoring, lots and lots of monitoring, continuous EKG, end tidal, respiratory rate, whole shebang, everything. And we're going to be doing this approximately every 15 minutes for the full 4 to 6 hours at least. The doctor will do serial neurologic exams. I do want to take this time to point out, no menace, palpebral, or PLRs for at least 1 hour post-arrest is normal. That has no bearing on actual patient outcome. And it can be delayed for 6 hours, for that 6 hour mark. So even though we're not seeing all of these lovely things that we want to see return, it takes time. And just because it doesn't come back for the first 1 to 6 hours doesn't mean that this patient is doomed. And then we, for any seizure activity, Keppra is the drug of choice. And please do not be alarmed if there's not much change within the first 6 hours. And again, this 6 hour mark, if they're going to rearrest, they're likely going to do it within this 6 hour mark. So even though we have 20 minutes, that 20-minute code that we're trying to get these kids back, the post-arrest care is not to be diminished. So we do have the backside of our CPR logs, have this. This is just to get us started. This is not going to last us for the full 6 hours of monitoring. So once that sheet's full, grab some anesthesia sheets to provide the documentation of the patient monitoring. And again, all these vitals are going to be monitored and reported at least every 15 minutes. Debriefing. This is something that gets left behind a lot, and I would really need us to start doing this. After every single code, it only needs to take maybe 2 minutes. But it should occur after every single code regardless of outcome, whether we got them back or what if we did not get them back. Again, only takes 2 to 3 minutes. It is a time for discussion, not a time to point out, Matt, you didn't call out those times, you failed. Not a time to point out, Amanda, your chest compression sucked. That is not the point of this debriefing. The point of this debriefing is, Matt, thank you for keeping us on track. I really appreciated when you gave us the 30 seconds heads up between chest compressors. Amanda, you did great on your chest compressions. That end tidal didn't fall below 15 the whole time. This is a time to discuss not only what went well, but what you learned, what you would like to see change in the future. But most importantly, it's for us. We are humans. We just our adrenaline went from 0 to 100 in a very short period of time. It's physically hard, it's mentally hard, it can be emotionally hard if we were attached to that patient. This is the time for us to take care of ourselves, not only so that we can do this better in the future or do it faster for the next code, but we also have to take care of each other. We have to be able to take that minute to take a deep breath before we have to hit the ground running again and go on to the next task or the next patient. Take the 2 to 3 minutes to help each other out. It's only going to benefit future patients, and it's really only going to benefit us.
Does someone lead that process?
Most of the time the DVM has then recused themselves to the patient or to the client, and then at that point it should be a team effort. There's not anybody that's specifically associated with it. It should just be, let's talk about what just happened. And it sometimes can be, that sucked. I'm sorry, I'll do better on chest compressions. Just some kind of conversation between the humans that are left in the aftermath of what just happened. Does anybody have any questions?
Will we maintain intubation for 4 to 6 hours after it happens, but is this going to be under anesthesia
They will oftentimes require heavy sedation. At that point, what will happen is that patient will be moved to the table in ICU, and lots of monitoring equipment, bear huggers, and a technician will be assigned to that patient. The technician will not leave that patient's side. And then it's not uncommon that, depending on the disease process that caused them to code, it's not uncommon that we'll have to do ketamine or fentanyl or propofol, something to keep them under for the full 6 hours. Any other questions?
If you get through 6 hours, what's the statistics of survival?
I don't have those numbers. Dr. Welch might have those numbers, but I don't have those numbers. Somebody else asked me that too. Well, thanks for your time. Next time we have a code, we'll rock it out, and then we'll take care of each other. Thanks, guys.
Thank you.
You guys.
In case anybody didn't sign the assistant sheet or the tech sheet up here.